Hello everyone and welcome to this webinar on the principles of Aboriginal and Torres Strait Islander health research and engaging meaningfully with community. My name is Erin McCallum and I'm the Acting Director for the Targeted Translation Research Accelerator program at MTPConnect, and I'll be your MC for today. In the spirit of reconciliation, MTPConnect acknowledges the traditional custodians of country throughout Australia and their ongoing deep connections to land, sea and community. Today, I am on the lands of the Wurundjeri people of the Kulin Nation. I pay my respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people joining us today. Can I have the next slide, please? Before we get into the session, I just wanted to cover off a few pieces of housekeeping for you all. Today's webinar will include presentations from each of our speakers, followed by an audience Q&A. To submit questions, please use the Q&A box rather than the chat box. Questions can be submitted anonymously, but if there is a need for any follow-up, we will not be able to contact you. However, the team can be contacted via our TTRA email address, which is displayed on the screen. If you have the same question as someone else, you can upvote that question and that'll raise it to the top of the list. And for those of you who wish to review this webinar at a later date, or if you have colleagues who couldn't attend today, there will be a recording made available as an on-demand video on the MTPConnect website. We will also be turning the session into a podcast and we will notify all registrants when it is published. And just a final note to please be aware that this webinar may contain images, voices or names of deceased persons. Next slide, please. Now onto our excellent panel of speakers for the day. I'd first like to introduce Dr. Mana Liao, Acting Senior Director of the TTRA program. Mana will provide a brief overview of MTPConnect and the program for those of you who are unfamiliar with us. The third member of our TTRA team, Anzion Parlade, is also online with us. She's driving the slides in the background, and thank you, Dee Dee. Mana will be followed by presentation from invited speakers. They all have very impressive bios, and if I was to cover them in depth here, we would have no time left for the webinar. So instead, I will just say a few words to introduce each of them, starting with Professor Alex Brown. Professor Brown is an Aboriginal man who grew up on the south coast of New South Wales. He is a highly accomplished clinician researcher and has worked his entire career in Aboriginal health. Alex is Professor of Indigenous Genomics as part of a strategic partnership between Perth's Telethon Kids Institute and the Australian National University, and recently formed the National Indigenous Genomics Consortium. Alex also co-chairs the MRFF Indigenous Health Research Fund. Next, we will hear from Dr. Michelle Kennedy. Dr. Kennedy is a Wiradjuri woman who has grown up on Worimi country. Michelle partners with Aboriginal communities to place the power in their hands and address priority areas to improve Indigenous health. Michelle is the Executive Manager of Research and Knowledge Translation at the Lowitja Institute and is also the Assistant Dean, Indigenous Strategy and Leadership for the College of Health, Medicine and Wellbeing at the University of Newcastle. Last but certainly not least, we will hear from Ray Kelly, a proud Gamilaroi man and one of Australia's leading health professionals with over 31 years experience in the health and sports industries. Ray is an accredited exercise physiologist and researcher and is focused on the reversal of type 2 diabetes in the Indigenous community. I'll now pass over to you, Mana.
Thank you so much, Erin. Good afternoon, everyone. Thank you for joining us today. As introduced, I'm Mana Liao, Acting Senior Director of the TTRA program. I would also like to acknowledge that I'm on the beautiful land of the Darug and Ku-ring-gai people in New South Wales today, and I pay my respects to their elders, past and present. So first, let me tell you a bit about MTPConnect. Can I have the next slide? Great, thanks, Dee Dee. So we are a not-for-profit industry growth centre that was set up in 2015 to support the growth of the medical technology, biotechnology and pharmaceutical sectors. We are to champion the sector by working with all stakeholders across the MTP value chain in meaningful ways to advocate as a trusted, independent advisor, promote greater collaboration, both nationally as well as internationally, and to drive innovation and productivity. MTPConnect also delivers funding for strategic initiatives. And as summarized on this next slide, MTPConnect is currently deploying more than $182 million of funding on behalf of the Department of Industry, Science and Resources and the Department of Health with its MRFF initiative. Through DISA, the Growth Centre program supports 40 projects that focus on infrastructure or capability and capacity building, including the establishment of the Breach Tech and the Breach program, and more recently, the Australian Antimicrobial Resistant Network and the Industry Genomics Network. On the Department of the Health side, we are currently operating 5 MRFF initiatives: the BioMedTech Horizons program, BMTH, the Biomedical Translation Bridge program, BTB, and Clinical Translation and Commercialization MedTech, CTCM, have now completed their funding rounds, with significant funding injected into nurture the translation of medical innovations through to the commercial proof of concept to early clinical trial stage. But we also have 2 programs that still have opportunities available. The first program is READY, our Researcher Exchange and Development within Industry program, which aims to drive skills development and workforce training in the sector by supporting workshops, fellowships, and internships for researchers and clinicians to get industry experience, as well as mentoring programs for PhD students and the ECRs. The details are on our website, which we encourage you to access if you're interested. And the other program is TTRA, which I'll tell you a bit more in the following slide. As you have heard, we have lots of acronyms with our program. So the TTRA stands for Targeted Translation Research Accelerator. It is a $47 million program specifically designed to provide a new integrated research program to improve the prevention, management, and treatment of diabetes and cardiovascular disease and their associated complications in Australia. A unique aspect of the TTRA program compared to the other MRFF programs that MTPConnect delivers is that TTRA funding is drawn from the Public and Preventative Health Initiative of the MRFF. So there is a focus and balance on health equity approaches as well as commercial objectives. The ultimate goal is to see Australian diabetes and cardiovascular disease research tend into new treatments for patients, a reduction in the burden of chronic disease, and the flow-on benefits like saving in our health system as well as job growth. So the TTRA is deployed across 2 key pillars. The first was to establish through a competitive process 2 national research centres, one for diabetes and the one for cardiovascular disease. The Australian Centre for Accelerating Diabetes Innovations, ACADI, and the Australian Stroke and Heart Research Accelerator, ASHRA, were both announced as the funding recipients in January 2022 by the Minister for Health and Aged Care. They will be funded for 4 years through the TTRA with $10 million each, and there is an expectation that they will be sustainable thereafter. Both centres have placed the focus on finding solutions to reduce health inequities as well as support health workforce development for the Indigenous communities. Our speakers that you'll hear soon today, Alex Brown and Ray Kelly, lead these important initiatives at ASHRA and ACADI respectively. In addition to the research centres, TTRA also provides contestable funding opportunities to support individual diabetes and cardiovascular disease research projects as our Pillar 2. To date, $11.9 million have been awarded to 16 research projects through 2 rounds, attracting an additional $17.7 million in contribution from academia as well as industry. These projects are addressing the priority areas called for in diabetes and cardiovascular disease and its complications, and progressing digital health, medical devices, therapeutics, or standalone behavioral interventions. To support and incentivize translation as a natural course of activity for those applying, as well as receiving funding, MTPConnect also partnered with leading organizations to provide mentoring and commercialization as well as implementation advices. So the TTRA program aims to maximize its investment by funding targeted needs. And for this reason, the priority areas that informed all the funding calls to date were identified through an evidence-based national coordinated health sector needs assessment. With this approach, we hope to see accelerated clinical impact for those who need it most. Although we recognize that previous approaches have its limitations, such that the previous needs assessment didn't truly represent the needs of the Aboriginal and Torres Strait Islander groups. So to really deliver targeted impact to those underrepresented populations, for this third and final round of TTRA research project funding opportunities, we are focusing specifically on supporting diabetes and cardiovascular disease projects that address the unmet health and medical needs of Indigenous people in rural, remote, regional, and urban centres. For this round, we want to ensure Aboriginal and Torres Strait Islander communities' voices and experiences are centred at all stages. And in preparation, MTPConnect has partnered with Lowitja Institute, a community control organisation, and Australia's National Institute for Aboriginal and Torres Strait Islander Health Research to lead this prioritisation project to determine the Indigenous-specific priority areas for this focused round. Additionally, to guide this delivery and implementation of the Round 3 research project funding opportunity and to maximise its impact, MTPConnect has established the TTRA Indigenous Advisory Group to involve prominent Indigenous researchers, clinicians, thought leaders, as well as representatives from organisations that have deep engagement with Aboriginal and Torres Strait Islander communities through direct healthcare delivery. And we are currently in the final stages with the prioritisation work, and we anticipate communicating the priority areas for this round before the end of the year. And you could learn more about the program and sign up to our mailing list to stay informed by scanning the QR code that's displayed on the screen. We appreciate that some audience members today may have questions about the specifics of Round 3. Although we are unable to share any specifics beyond what has been presented, as we are still finalising the details, we do hope to share those details of the round with you all in the coming weeks. So please watch this space. So that's an overview about MTPConnect and TTRA. As there are many of you today virtually, although we can't see your faces, we would love to learn a bit more about you. So we're going to put up 2 polling questions for you to complete on your screen. I'll keep them up for about 30 seconds. The first is to understand a bit if you have heard or familiar with the TTRA program before joining this webinar. And the second question is around, are you involved in Aboriginal or Torres Strait Islander health research related to diabetes or cardiovascular disease or both? So we'll probably give that another 20 seconds or so before we close up the poll and find out about the result. Great, thanks. We can see the result now on our screen. So with the question, were you familiar with the work of the TTRA program prior to this webinar? We have 15% people who are very familiar with us. 27% of people said they're somewhat familiar, and quite a majority of you said no. So that's really a great outcome. So that really means that we have approached the people that we haven't previously targeted, and we want to build more awareness in this space. That's excellent. The second question, are you involved in Aboriginal or Torres Strait Islander health research related to diabetes and or cardiovascular disease? So 34% said yes, and 13% said yes, research in the Aboriginal research space, but not directly related to diabetes and cardiovascular disease. And there's also a 53% of our audience today are not directly involved. So again, thank you everyone for completing the poll. This really gave us some insight of the potential applicants who would be interested in round 3, but also it provides us some insight of which direction we need to focus on building those awareness for this round 3 as well. So I will now leave to Erin to proceed on the next speaker. Thanks, Erin.
Thank you, Manna, for that great overview and for those interesting poll results. We will now hear from the first of our invited guests, Professor Alex Brown. Over to you, Alex.
Great, thanks very much, Erin. And it's really wonderful to see over 170 participants joining us online, some of you for the first time. And I'm sure there's some of you who have been well engaged in research with Aboriginal and Torres Strait Islander people before. Obviously, the question is why the cardiovascular and diabetes space is so important to Indigenous health. Well, probably the key architecture of response to that is that alone cardiovascular disease accounts for about 25% of all deaths of Aboriginal and Torres Strait Islander people, and a similar amount of the inequalities that we see in life expectancy. So CVD and how diabetes contributes to it independently, as well as synergistically, is a really important part of the story. We've been involved in cardiovascular and diabetes research for some time, largely because of some of the data that's put before you on this slide. We see significant inequalities, both in terms of the absolute burden of disease, but also the onset of both cardiovascular conditions and diabetes and its complications in Aboriginal and Torres Strait Islander communities. And this is a particular pattern that concerns us greatly. You can see in the top right-hand side, this very, very premature onset of CVD and CVD mortality in our communities. We also see very aggressive phenotypes, or what we would say clinical pictures. On the bottom right-hand side, this is a comparison of the rates of end-stage renal disease in Aboriginal and Torres Strait Islander people compared to the rest of Australia. And at all age groups, we see a markedly increased rate of disease, and the vast majority of end-stage renal disease is driven by diabetes in our communities. But we've also become very interested in the propensity or risk of children born to mothers with type 2 diabetes developing type 2 diabetes prematurely themselves. So this intergenerational transmission. So these frame, in many ways, why we need to be focusing on these conditions. Next slide, thanks. Now, this just breaks this differential down a little bit further, and you can see here trends over time in the rates of death from coronary heart disease or atherosclerotic heart disease, comparing the rates in Aboriginal and Torres Strait Islander women compared to the rest of the community. And you can see over time in these age groups, there have been declines in the rate of disease or the rate of mortality from cardiovascular disease. But unfortunately, the gaps between Indigenous and non-Indigenous Australians are still massive, particularly at young age. And there is still evidence that those gaps are widening, particularly in the 55 to 69-year-old age group, as you can see in this data. So there's a lot of work yet to be done. Next slide, thanks. So the question is, well, how do we make sure that the history of how research and scientific endeavour has played out in Aboriginal and Torres Strait Islander circles is not repeated? There is a legacy of how research and science has treated Aboriginal and Torres Strait Islander people as the object of research rather than partners in research to make a difference around things that matter most to Aboriginal and Torres Strait Islander people themselves. And this approach of true partnership, engagement, and working with Aboriginal and Torres Strait Islander people about what matters most to them and what their aspirations are is a fundamental requirement of moving forward in cardiovascular and diabetes research, in fact, in any area of research of relevance to Aboriginal people. Next slide, thanks. So one of the challenges we face is that many people in policy, in systems, in healthcare delivery have a sense that they've got the solutions to overcome Aboriginal health inequalities, but that hasn't been the case. And fundamentally, there is a requirement for us to get better at working with Aboriginal and Torres Strait Islander people around their own solutions, their own skill sets, their own expertise, and working in partnership to make sure that we can come up with innovative solutions to some of the intractable challenges and problems we've been facing, both in the context of cardiovascular disease and diabetes, but more broadly as well. Next slide, thanks. Now, if you're wondering, or you haven't been engaged in this space before, there are a raft of materials that can help you frame your thinking, that can guide you in the expectations that most of the major funding systems within this country have to guide you in undertaking research the right way with Aboriginal and Torres Strait Islander people, communities and services. The NHMRC is one of those bodies, obviously one of the key funders of research for health and medical sciences in this country. And they have clear guidance around what the expectations are. So if you are not familiar with these guidelines around ethical conduct for research in Aboriginal and Torres Strait Islander peoples and communities, it would be a critical part of your preparation for any grants to come forward. Next slide, please. There are also guidelines available from the Australian Institute of Aboriginal and Torres Strait Islander Studies, or IATSIS, based in Canberra. These are probably the most contemporary of the guidelines that exist. These are extremely well written, extremely clear, and should provide very clear guidance to anyone thinking about entering or undertaking Aboriginal and Torres Strait Islander research, whether that be in the context of health and wellbeing, or broader in terms of social and cultural and environmental matters as well. The core components within this architecture, these guidelines speak very clearly about the importance of Indigenous self-determination in all that's done within a research agenda, the importance of Indigenous leadership, both in terms of leading the research, but also ensuring that Aboriginal and Torres Strait Islander ways of knowing and understanding are incorporated into the way in which the work is to be done. There's a clear requirement for ensuring that the work to be done has benefit, that's not just esoteric, but has meaningful and tangible impact on the health and well-being of Aboriginal and Torres Strait Islander people towards outcomes defined by Aboriginal and Torres Strait Islander people themselves, and that there is an assurance through research of accountability in the processes that are undertaken, and also not just the way it's done, but also the outcomes to be delivered. So I recommend to you to read through these documents. Next slide, thanks. There are also a raft of literature that could help you think through what expectations you could anticipate would be placed on a call for research that's specifically targeted towards responding to the needs of Aboriginal and Torres Strait Islander communities. There are a raft of criteria for how you should report research. This is also a very useful way of starting on the right foot and thinking through the things that you need to be mindful of when developing research projects. There is guidance around key principles to guide your thinking and actions. There are documentation from Aboriginal and Torres Strait Islander people about how you need to be thinking about the support that you need to be providing for Aboriginal and Torres Strait Islander people's leaderships and roles within research. And there are ways of considering how to ensure the quality of your research according to Aboriginal and Torres Strait Islander principles and sensibilities. So there are plenty of things out there to help you think through in a development phase what you need to do. Next slide, thanks. There are also local guidelines. This is the South Australian Aboriginal Health Research Accord, for example, which takes the next step really on what the expectations or terms of engagement are between Aboriginal communities here in South Australia and people engaged in research. These important mechanisms to consider are not just ensuring that the research aligns with Aboriginal and Torres Strait Islander people's priorities, but it includes them at all levels, that it's guided by true partnership, that is respectful of Aboriginal ways of understanding the world, that it's communicated appropriately, that it delivers something tangible, that the process is owned in partnership with Aboriginal and Torres Strait Islander people who are able to maintain some control over the way in which it's done and what it delivers. And you have to make sure that it delivers something beyond a research paper, but can translate into something meaningful in terms of health impact. Next slide, please. Similarly, there are strong conversations across many Indigenous communities, not just here in Australia, but certainly across the globe, about the importance of enabling Indigenous people to ensure that the way in which work is done and the outcomes of that work adhere to Indigenous ways of thinking and being and managing. This is in the context of data sovereignty. Lots of people are talking about it. What this speaks to is the importance of engaging in partnership to ensure Aboriginal and Torres Strait Islander people have a say in the work that's done, the data that's collected, how that data is interpreted, and how it's used to deliver benefit. Next slide, please. Similarly, if you're wondering if you require further guidance, the Uluru Statement from the Heart, although not specifically written about research for diabetes and cardiovascular disease in Aboriginal and Torres Strait Islander communities, has very clear principles to guide your thinking about the importance of Indigenous people in control of their own destiny, of the important impact that a range of social factors can have on the health and well-being of Aboriginal and Torres Strait Islander people, and about the importance of the next generation and our contribution as a research community to reducing inequality over the longer term. Next slide, thanks. If you're further concerned about, well, what sort of diabetes and cardiovascular research should we be doing? How can we be guided in that? The Close the Gap targets, clearly articulated as a partnership between the Australian Government and Aboriginal and Torres Strait Islander health and social service leaders across the country, clearly demarcates a range of targets for change that will make meaningful impact on the health and well-being of Aboriginal and Torres Strait Islander people in the future. Now, you'll say that some of these targets aren't specifically about heart disease or diabetes. That's true. However, each of these are important to contributing to the health and well-being of our community and could be considered within the development of research applications for the future. Next slide, thanks. So the other consideration is not just to think that you've got all the answers. It's really important to engage with Indigenous peoples and communities and elders and knowledge holders about what their understanding can offer the way in which we do research and the way in which we develop interventions that can make a difference for the future. We have tremendous strengths as Aboriginal and Torres Strait Islander people. To ignore these would be a wasteful opportunity to develop truly innovative and translatable research for the future. Next slide, thanks. So our advice, my advice in terms of thinking about what are we going to do to develop an Aboriginal cardiovascular or diabetes research piece. One, it's really important that we move beyond describing things. It's time to move to interventions and developing solutions that work on the ground. It's really important you understand that community engagement is not optional, it is essential. We've often had to deal with people considering that Indigenous health research funding is easy money and we'll just run our flag up the pole and do something in the Aboriginal and Torres Strait Islander space. That's not the case. There'll be a rigorous evaluation process to ensure that the grants that do get funded are done appropriately and are mindful of Aboriginal and Torres Strait Islander principles. I often give advice, if you think you can do Indigenous research as a hobby, it's time to get a new hobby. If you're not committed to employing Aboriginal and Torres Strait Islander people within the work that you do, probably not the best funding scheme for you to enter into. If you don't know, make sure you ask. Partnership and relationships with communities is essential. Don't be obsessed by the things you can't change, be driven by the things that you can. And that's why we're seeking a broad community to come up with solutions that will make a difference. And remember, where inequality exists, it's everyone's job. Duty does call, and we are looking for innovative solutions to make a difference to the health and well-being of our communities. I'll leave it there. Erin, thank you.
Thank you, Alex, for that really excellent presentation. And just a reminder to our audience that the Q&A will follow all three presentations, but if you've got questions in the meantime, feel free to put them in the Q&A box. Next up is Dr. Michelle Kennedy. Michelle, the floor is all yours.
Thank you so much. If we can flip slides, and again, maybe, would be good. So lovely to follow, Alex. Thank you so much, Alex, for opening up for us. I want to acknowledge and pay respects to the unceded lands, skies and waterways on which I'm connecting with you all from, the lands of the Awabakal Worimi people. I'd like to pay respect to our elders past and present for their continued connection and caretaking of these sacred lands since time immemorial. And I'd also like to acknowledge all Aboriginal and Torres Strait Islander people connecting with us today. Next slide, please. Before I enter into a discussion on principles of Aboriginal and Torres Strait Islander health research and engaging meaningfully with our communities, I want to acknowledge that Aboriginal and Torres Strait Islander people have been conducting research since time immemorial, which is evidenced by our continual survival in spite of colonisation and contemporary colonisation. I want to acknowledge the people that taught me well before a university did, before I read a peer-reviewed journal article or attended a webinar on the topic, my Worimi community. It is these people and elders who first taught me about good governance and good ways of working, which are integral to ethical research practice. Our community have not always had positive experiences of research, and they continue to be really cautious of researchers. Recently, I attended an elders meeting with our community to talk about research and seek their wisdom and guidance. And they commented how different research is when it is conducted by our mob. One auntie was commenting how researchers don't usually explain why they are doing the research or what it's for or how things are going to change for us from this research. So my community, like many, are asking for research to do something, to change our lives for the better and for our future generations. Next slide. By way of positioning myself, I am Michelle Kennedy. I'm a proud Wiradjuri woman raised on Worimi country, and I have the absolute privilege of being the Executive Manager of Research and Knowledge Translation at the Lowitja Institute. I'm also a research fellow at the University of Newcastle, and I have an undeniable passion for Aboriginal and Torres Strait Islander led, owned and informed research. So as I mentioned, I've not grown up on my lands. I've grown up with this elder here on beautiful Worimi country. And it is these lands and people who raised me, these people who took me out on their country and taught me what it means to work within our ontology, our way of being, our epistemology, our way of knowing, and our axology, our way of doing. I am a mother, a stepmother, auntie, sister, artist, social worker, and now Aboriginal health researcher. Next slide. I am also what my people would call a Doris. I like to know things, be across the latest goss, and in academia, that means across the latest literature. So it led me to do a rather large piece of work that I thought I would speak to in this webinar. So rather than me offering a reflection on my ways of conducting research or what ethical guidelines, principles, and values teach researchers that they must do, I'll tell you what I've read that researchers are doing and what we know works and is needed for your next project design or grant application. So I thought it would be fun to know all the research that's been conducted in Aboriginal and Torres Strait Islander health. And I'll let you know that there is a little bit of reading involved in doing that. So recently we published this large narrative review which examined the 2,150 peer-reviewed manuscripts that have been published specifically on Aboriginal and Torres Strait Islander health since the establishment of Closing the Gap. This review provides a bit of a snapshot on the scope of research that's been conducted, on what areas of health and well-being, as well as the locations in which research is being conducted. And I encourage you to read this. It took a long time to read all of these research articles, but I'm not going to spend my time speaking to this publication because you can access it and easily read it. So I rather want to speak to a secondary review that we've just conducted. So after understanding a bit about what researchers are researching, we really wanted to understand the ways in which researchers are conducting research from their perspective, and more specifically, what researchers report as being a strength and limitation or barriers and enablers of their research practice. So this led us to undertake a secondary review of interventions and evaluation studies. So since 2008, 240 interventions and evaluations have been completed and published in Aboriginal and Torres Strait Islander health. So we took those 240 publications and looked at what researchers reported in their strengths and limitations section of their manuscript. Next slide, please. This is what I want to offer you as some guidance now. So we want to note that not all researchers offer reflective practice on strengths and limitations of their research, and journals have different criteria of these expectations for this. But we really wanted to be able to inform future researchers about what is going to work in designing and implementing effective, meaningful research with our people and communities. Next slide. The most commonly reported strength to research practice, which is what we've just heard Alex speak to, is the essential nature of community consultation and collaboration. Community consultation and collaboration is inclusive of engagement with elders, traditional owners, Aboriginal health services, and other Aboriginal organisations. And it's reported across all different phases of the research process. This would often come into the form of formal partnerships, co-design, and interpretation of findings. Consultation and collaboration are identified as important in ensuring that programs meet the priority areas identified by community. These partnerships involve an ongoing and continuous relationship, constituting more of a partnership than a one-off consultation. As Alex said, we don't want people coming into our communities, speaking to us, getting a tick and going off and getting a grant to write more research publications on our people that may or may not lead to positive change for us. The second most commonly reported strength was Aboriginal and Torres Strait Islander people as part of the research team. I want to note that while we are a minority group, there are many Aboriginal and Torres Strait Islander researchers, health workers, health service managers, community members who all have skills and knowledges to share in research practice. Aboriginal and Torres Strait Islander leadership is key to meaningful engagement, to ensuring our community priorities are met, to delivering research in a culturally safe environment, building rapport, and enabling a research team to contribute to capacity building, both of themselves as researchers and also of our communities and community organisations. This leadership of Aboriginal and Torres Strait Islander people is also key to incorporating local culture and context. Our communities are diverse, and we need to ensure that research is reflective of our diversities. There is no one way to conduct research or one best practice model. We need to ensure that those are driven by our communities and meaningful to them. Critical to partnerships and leadership in Aboriginal and Torres Strait Islander research is the appropriate allocation of resourcing. Next slide, please. Timeframes that were reported as both a strength and a limitation. We know that time is critically important. As we mentioned previously, research partnerships should be ongoing, not a one-off consultation. Community engagement, governance, and ethics all require time. These can't be fast-tracked or skipped over. So while a researcher reported challenges in community involvement and communication as a limitation, we know that the strength is that if community leadership and partnership is integrated, that this is no longer a barrier. Next slide. This process of conducting a review of barriers and enablers in research, or strengths and limitations in research, reinforce what my Warramai community were already telling me. And the good news for researchers is that nearly all the barriers or challenges to doing research can be mitigated if you conduct research in Aboriginal and Torres Strait Islander health the right way. That means that we need to have community consultation. Our communities need to drive the research prioritisation, design, implementation, analysis, and knowledge translation. We need to be embedded in the whole life course of your research project. not cherry-picked for the moments in time that you would like us to be involved in. If we co-develop appropriate timelines through that strong consultation and partnership, we will be able to consider a research design that is appropriate to the communities in which we're conducting research. We will know the expectations of the community, of our governance committees, of ethics committees, and these can all be factored into early planning. As Alex mentioned, if you think this is going to be a hobby to come in Aboriginal health research and you don't have this planning, you need to get a new hobby. We aren't changing the systems or structures that are in place, particularly for ethics. A lot of researchers speak of how hard and complex Aboriginal health ethics is. We fought long and hard to get ethical processes and governance over research, and we have them in place for a very valid reason. So researchers need to really understand the landscape in which they're wanting to work and plan their research around that landscape. Don't look at what works in a general population or a hospital setting and think it's going to work in our communities. We need to carefully address the funding allocation and employment and leadership of Aboriginal and Torres Strait Islander staffing on your research. Next slide, please. Taking it a step further, I want to make some recommendations for all researchers conducting research in Aboriginal and Torres Strait Islander health to do 3 core things. Fund the employment of Aboriginal and Torres Strait Islander personnel across all stages of the research and all stages of your areas of your research team. You need to provide appropriate and adequate reimbursements to Aboriginal health services, and it is those health services that will tell you what is appropriate and adequate. And to integrate knowledge translation activities in the program of research and fund it so our communities know what has come out of this research. Next slide, please. You know something is really important when 2 Aboriginal academics show you the same piece of literature to read. For those who haven't read this piece of work yet, I want to offer it to you as it's really good grant writing guidance and also a check-in point. I personally use this for every publication that we submit. So this excellent article was produced some years ago by Associate Professor Lisa Wapp, Ali Drummond, and Professor Chelsea Watergo, and it's coined the Blackfella test. Next slide. The Blackfella test has 11 points, and many of these were already covered in Alex's presentation. We don't want people to have good intentions anymore. We don't want research to speak of our disadvantage without making mention of colonisation, how that's impacted our health, or not to mention racism. Please don't refer to us as your Indigenous or use acronyms for who we are. We are Aboriginal and Torres Strait Islander people. Please don't use our statistics, deficit statistics, and speak to them as being alarming or appalling. Next slide, please. We are not just at-risk and vulnerable people. We are people with inherent strengths and abilities. We want to speak to those strengths. We do not need research to simply monitor to understand our ill, deficit health outcomes. We don't need deficit statistical portraits of our health and well-being. We want to acknowledge that Aboriginal people are not just advisors on a research project, but leaders, and ensure that when you're looking to develop a research paper, you look to what Aboriginal and Torres Strait Islander academics are writing about and ensure that they are privileged in your reference list. I will close it there and answer any questions in the Q&A section.
Thank you so much, Michelle. I'm sure everybody will have lots of questions after that, but before we get to those, let's hear from Ray Kelly. Over to you, Ray.
Hi, everyone. Thanks for coming in today, and some great advice there by Alex and Michelle. My name's Ray Kelly. I'm a Gomeroi man from northern New South Wales, and I've been working in health for about 31 years. And I guess I leaned into cardiovascular disease and diabetes through my own family's history, where my grandfather died at the age of 52 and my uncle at 44. Today, I'll be talking about how I formed a successful program on lifestyle within primary care, but how it was improved by working with community and just some of the specific things that we learned along the way. But I'd like to start by acknowledging the traditional owners of the lands I'm on, the Darkin Young people, the beautiful area of the Central Coast on New South Wales. Next slide, please. I wanted to touch on this one because this was a piece of artwork that jumped out at me as soon as I saw it. It was done by a Gomeroi artist, Shanice Allen, and it's called Healing Within Community. And I had to purchase it, and it's now the artwork of my PhD, which I'm completing out of the University of Melbourne. It's, as you can see, there's a total connection, and this really does represent how research should be completed. Next slide, please. So my program's called Too Deadly for Diabetes. And what happens is we train local staff at the Aboriginal Medical Services, and they provide the they provide the program themselves, and I just train them up and provide the structure. Usually goes for 10 weeks at a time. They usually run 3 or 4 programs a year, and it's been quite successful. To give you an idea, Canamble, which is a population of about 2,700 people, they've just passed the 2,000 kilo mark for patients on their chronic disease program. That's just run by a practice nurse and the Aboriginal health worker. So the reasons why it works, it's research based. So we look at what the research actually shows does work. It's community involved right from the start. So we work in with the community, we go in and we find out what are the strengths of the region, what are the barriers that they've had in the past, and what solutions we can work on together to improve those or limit those. We train the local staff to run the program so that we've got that continuity long term. We take a strength-based approach because we know that Aboriginal people know how to improve or take control of their health if they're given the right information and support, and the program shows just how effective that is. And it's a solutions-based approach. So rather than looking at barriers and obstacles and just accepting that that's part of life, we come up with solutions to get around those. And we keep it simple so that it's easy to implement no matter what your lifestyle is. And this leads to just empowerment of the patient. So the patients themselves can guide the direction they need to go in and make the decisions that need to be done. Next slide, please. Probably the best way to tell the story, though, is to let some of the patients actually talk through their results. So just a short video here.
My name's Barb, and I've lost 23 kilos, and I am diabetic free after 34 years.
I am now off all insulin. That was Novorapid and Atlantis. None.
Yeah, when I started the program, I was on 2 tablets. Now I'm on half a tablet.
My insulin doses have dropped from up in the 30s down to the 10s and 9s and 10s.
My insulin, I started 160 a day, and I've dropped down to 20 units a day. So yes, I'm happy. I went to 4 injections to 1 injection a day.
I've had sugar levels that were 24, 18, 22, but now I'm down to 7. And I'm so proud and happy about that. I know we can beat this diabetes.
I started the program with the AMS, and then I came off insulin in the first 7 days, and I've never looked back with the insulin. I don't miss that. I hated the needle.
So as you can see, these are just people from community who were given simple strategies and the right support, and they've been able to really make improvements in their health. Next slide, please. So some of the strategies that we got into place. This one just always stood out because, you know, my father couldn't read and write, and so I always tried to make sure that, you know, I didn't sort of make the instructions too wordy and double spaced and large font and all these sorts of things. But then Margot came along and she started on the program. She had a meal plan, and she would walk in one day for a bit of exercise, and she said, you know what, like, I'm going real good, but I got to try and find my glasses every time. I've got it on the fridge, what I've got to have, but I've got to go and find my glasses all the time. And it just made obvious sense that we put some photos on just a simple format that people could sort of identify pretty quickly. And that ended up going from just being in the Burke program to all of our programs around all the locations. And it's something that's been quite effective. Next slide, please. When you look at the barriers for even within attendance in research or within lifestyle programs or any programs at the health services, you'll find that work and family commitments are common issues. And so we had people saying, look, you know, I can come in this week, but I won't be able to come in for the next 2 weeks. And it could be just traveling with work. It could be traveling for medical attention for other issues that they've got appointments in neighbouring cities or towns, or just having kids at home or not having access to transport for that one day. So we decided to allow people to phone in their weights and their BSLs and so on. And it worked out really well. So some people were thinking, like some of the staff were saying, well, they might lie, you know, like, but people don't, and it's worked really, really well. And it's such a simple little change that maintained that engagement, so we could still discuss things on the phone with people, just that they couldn't come in. And what we found too was that a lot of programs are run during work hours, so you can see where that work commitment can be quite a barrier. So it's certainly a consideration moving forward for anyone looking to run programs. Next slide, please. This was a funny one because I just did not think for a second that people in remote communities would want an app. I was always just assuming that there would be issues with access to good internet and so on. And they were screaming for it. They wanted an app where we were using sort of SMSs and emails to move information and printed copies. And whilst all those things are still handy to have, people were saying, look, it'd be good to have it all in one location. So the app, and so we ended up developing the app a number of years ago, and it's been a huge success. And that's come specifically from community asking for it. Next slide, please. So what we found when we started off at Burke, the community were just really keen to improve things, that they could see the direction it was all going, and they just really were keen to get going. And so we had some sort of supervised exercise sessions going, but they asked, like, can we start our own walking groups? And I'm talking like there was about 4 or 5 different groups. And as you walked around the streets of a morning, you'd hear the dogs barking a few streets over, because the group that left at 6 a.m. We're walking through a different path, which you could see there. We had we started off, we got just the town maps, the tourist maps, and we measured out 500-meter walking track from the AMS, so starting at the AMS, and then 1,000 meters, and went up to 5 kilometers with 500-meter increments, so they could sort of increase that every week or two. And yeah, that just proved to be quite a positive thing. Next slide, please. And sustainability, so being able to prepare food. So some people, that they're sort of not very experienced in preparing fresh foods, and this is across the whole community, not just the Aboriginal community. And so this can be a real limitation when people are trying to improve their health with better food choices. So what we looked at was some of the established cooking groups that were in town that might have been run by other organisations. And we also tried to incorporate cooking lessons where we could, where we had dietitians available or so on. But we also included in some of our starter packs, a 15-litre pot for making soups and curries and so on, and a stick blender for soups. And there was a few other things, slow cookers and things. At different locations, we use different tools, but it was just something that came about through people saying, look, I want to eat healthier, but I'm just not sure how to prepare these foods. Next slide, please. This was a good one because in Coonamble, I've never been to a town where the AMS actually owns the only gym in town. They hadn't owned it that long, but when we were running our first program, we were trying to get people in the community in there. A lot of the feeling was that they didn't feel like it was for them, like it was really just non-Indigenous people that went there. And so we had to sort of change that culture and improve that culture. So we started just the 2 deadly only classes, and people started attending those, and then slowly started coming and just doing the cardio on their own. And now we're 2 years down the track and they're all in there. So we've been able to utilize such a great strength of the community by just really trying to change that culture in there. Next slide, please. And I just wanted to give a shout out to just some of the communities we work with. And you wouldn't believe some of the results these guys get, you know, like these are just hardworking health workers on the ground, and they do all the heavy lifting with not much congratulations, but I'm here today just to give them a congratulations because they do such a good job. Some amazing work being done in the diabetes and chronic disease space by communities. And if you discuss you know, what's required with them, they'll tell you and they'll help you. But you know, you've got to be willing to listen, and that is really the key. Next slide. And I just wanted to thank my Brains Trust there, Professor Elif Akinji, who's the director of ACADI, and Professor David O'Neill, who's the new deputy director, Professor Margaret Morris, and Professor Linda Chiriloff. Thanks, guys.
Thank you so much, Ray. We just have a few minutes left, so I might quickly bring our speakers back onto the screen. I noticed that Alex and others have been answering some of those questions within the Q&A box, which is very helpful, but there's perhaps a couple that we can answer live. The first one I've got here is for Michelle, and the question is, over time, I feel community working in health have lost the will to get up and stand up. So how can this mindset be changed so community know that the power and influence is actually being transferred to them?
I'm reading this and thinking that's not what I see in my practice. And I'm very lucky to work at Lowitja Institute and work with communities across the entire country who are very empowered. We do need to acknowledge the history of research and the legacy of ill research with our communities. And so if I think of in the context of, if I'm talking to communities about leading research, Aboriginal-led research, Aboriginal-owned research, addressing community priorities, I don't think there is a mindset to change for research. And it's really important that as researchers, both Aboriginal and Torres Strait Islander and non-Aboriginal, that we are reflective of our own work. So even though I do a lot of tobacco research, that might not be a community's priority. So it might be that communities aren't, you know, getting up to a certain type of research because that's actually not their priority at this given time. So I think that comes back to, you know, really working with communities and building really solid, honest and trusting relationships with them.
And just quickly, that might lead into a question I think that's come across in a few of the different questions, is about how to proceed in terms of collaborating with community and getting them involved in research. If you have some final thoughts on that.
Do you want to jump in, Alex?
Any of the panel?
Yeah.
You can start, Michelle, and then I'll finish off if you want.
Well, I guess the way that I conduct research personally is that I allow researchers to come to me. I've never got on the phone and called a community and said, hey, do you want to do this research project with me? I have an ongoing commitment to Aboriginal health research. So any opportunity that I have to present the research I'm doing, to speak on things like a webinar, so communities can understand who I am, what I'm about and what I'm doing. And it allows communities to come to you. I really encourage researchers not to pick up the phone and say, oh, we need 3 sites in New South Wales for our project. We better just start calling AMSs and see if they want to get involved, but really set up genuine partnerships and allow communities to come to you.
I think that's really good advice. I mean, the other bit that's really critical is that everything that happens in Aboriginal and Torres Strait Islander health and policy and research is built on relationships. So you want to know how to go about doing stuff, build relationships with the communities in the first instance. That requires you to, reach out, be humble, respectful, and then find what it is that community wants that you might have skills to support. And that's a slightly different mindset.
Maybe I can just add there. I know we're running out of time, but just to say we're going to have a webinar survey. They're going to ask our audiences what your interested area for future webinars, because that's community engagement I think comes up multiple times today, and I think that's a key area we probably would like to do another webinar on, so we can give you a bit more insight around that.
Thanks, Manna. Yes, and in the interest of time, I know some of our panelists have other things to get off to, so that will bring to the end today. And I'll take this opportunity to thank all of our speakers, Professor Alex Brown, Dr. Michelle Kennedy, Mr. Ray Kelly, and our very own Dr. Manna Liao, for their time and for sharing their wisdom with us. This has been a really excellent session, and I'm sure we are all walking away with a lot to think about. I would also like to thank our audience for joining us virtually and ask that you please share your feedback with us by completing the survey that you can access by clicking the link that will appear once you log out of the webinar, just as Manna mentioned. And the survey will also ask about further topics that you might like to hear about as part of the TTRA Research Project's Round 3 webinar series. And finally, a thank you to the MTPConnect communications team and Dee Dee that have been working very hard in the background to make sure everything runs smoothly today. Thank you again, everybody, and we hope to connect with you again soon.